CataractCoach.com. Phaco for a patient with tremors. This patient has intractable tremors and titubations. And yes, I had to look that word up too. So our operating guest surgeon, here's Dr. Vipul Arora from India. And you can see this patient. This is the amount of tremor the patient has. Now, I know some of you will tell me, well, just put the patient under big general anesthesia and give them a paralytic agent in the IV while they're intubated. I guess you could do that, but is there a possibility of doing it without so much anesthesia? And in this case, the patient may get a little bit of sedation, and the patient can help cooperate to their ability, but you as a surgeon can actually still take care of this patient and do this case without too much stress. I'll explain. Now, obviously, Dr. Arora is a very skilled surgeon, so you probably want to have done at least 1,000 cataracts before you try to do this. But do remember, while you may have some head tremors or head movement, as long as they're small, you're okay, because when you have two instruments in the eye, you've got a 2-point fixation here. And so here's a nice little vertical chop. That looks beautiful. Very nicely done. Rotating the nucleus, and looks like further sub-chop. And so this is a nice technique. The vertical chop is a good choice in this case when you have these tremors. You don't have to put the chopper around the horizontal equator like you would for a horizontal chop, right? You can just keep both the phaco and the chopper within the confines of the rexus, so staying in that central endonucleus. And so now chopping and removing completely. Here's a case too where, if you have a patient that has tremors every so often, a lot of times these are very periodic that happen almost like clockwork every few seconds. You can time some of your motions here. I did have a video here on Cataract Coach about that. It's one of the toughest cases I ever did, where the patient had those same types of issues. But a case like this, I just want to put that out that if you are a surgeon who's more experienced, done at least 1,000 cataracts, you can help these patients without having to do higher degrees of anesthesia, and you can see patients doing pretty well. Now, one thing that I got to tell you, a very important pearl, in a case like this, never get upset at the patient. Patient has no ability to control this. And as long as you tell the patient you're doing a great job, everything looks fantastic, the patient will be more relaxed and it'll be easier for you. But the second you tell the patient, quit moving, or what are you doing? Keep looking at the light. And you have that stern tone in your voice, the patient will become more nervous, more afraid, and the tremors will be even worse. So remember, you've got that, sometimes we call that your vocal anesthesia, just by calming the patient down. And the way you say things and what you say can really make a huge difference here. And on a case like this, you're able to help a patient who truly needs your help, and you can get this case done without giving this patient such a high degree of anesthesia, like general anesthesia. So here's the end of the case here, just cleaning up everything. Looks like a BSS, maybe squirting, or filling the capsular bag with viscoelastic. Let's see what the lens is. Oh, we just fast forwarded to it. Dr. Arora gave us a fast forwarded case, but lens in the bag, and you can see the patient's going to have a beautiful outcome. So if you have a patient like this with tremors, yes, listen, I would strongly consider doing it if you're comfortable without doing general anesthesia. But if you have a more extreme case, or if you think it'd be safer in your hands to do general anesthesia, hey, go for it. It's all good.